My name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan, and this is the first Learn and Share conference call of 2013 entitled Ask the Epileptologist, and very happy to have with us today Yvan Tran, who's an epileptologist with Hauenstein Neuroscience Center at St. Mary's Healthcare. And Dr. Tran, can you, after I get this person marked down, can you just introduce yourself and kind of give an overview of your experience, your clinical and research interests, and then also talk a little bit about what it means to be an epileptologist. But before I do that, who just joined us?
Christy Straub.
Hi.
Hi.
Okay. Dr. Tran?
Hi, everyone. I'm Dr. Yvan Tran. First, I want to thank Russ and the Epilepsy Foundation of Michigan for inviting me to this wonderful dialogue series. I work as an epileptologist in Grand Rapids at the Hauenstein Neuroscience Center. The Hauenstein Center is a kind of a multidisciplinary center where we see a lot of different neurological problems. I work there as an epileptologist, and I primarily see patients with epilepsy in the clinic as well as in our epilepsy monitoring unit. Some of my interests include epilepsy surgery as well as women's issues in epilepsy. I've done research on areas such as surgical intervention, status epilepticus, and refractory status, as well as some research in what we call high-frequency oscillations. And it's my pleasure to be with you guys today.
Great. Well, as I mentioned, I'm just going to start by asking some questions about epileptology and what that actually means, and when to see an epileptologist versus a general neurologist, and those types of questions. Can you just talk a little bit about what specifically an epileptologist is for people who may not be familiar?
Sure. An epileptologist is essentially a neurologist who specializes in taking care of people who have epilepsy. So epilepsy from multiple causes. I'm an adult neurologist or epileptologist, so I see only adults. And I see people who have epilepsy who've had childhood epilepsy and now have epilepsy as adults. I see adults who have new onset epilepsy due to tumors, strokes. So a multitude of different causes for patients' epilepsies. And I also run the epilepsy monitoring unit here along with my colleagues, and we do different things to diagnose people with epilepsy and to offer treatments such as medications, surgery, or vagal nerve stimulator.
Okay, great. So it basically means you see primarily patients with epilepsy, and then also most epileptologists have done a fellowship in epilepsy, correct?
Correct. We do a training in general neurology, and then we choose to do between 1 to 2 years extra training just in epilepsy.
Great. Okay. So can you talk about some of the various circumstances under which a patient should see an epileptologist as opposed to a general neurologist?
Sure. I think any patient who has difficult to treat seizures or epilepsy should see an epileptologist, especially any patient who's tried more than 2 medications. There are studies out there that show that once you've tried more than 2 medications, that you should be referred to an epilepsy center to see if you could meet criteria for other types of treatments such as surgery or VNS. Essentially, any patient who continues to have what we call medically intractable seizures or seizures that don't respond to medications should see an epileptologist.
Okay. And are there other special circumstances, like, for instance, a woman who's planning on having a child she has epilepsy, or someone who maybe has I'm just thinking of other examples of possible situations where an epileptologist might be worth seeing, even if your seizures are fairly well controlled.
Sure. Oftentimes we'll see, especially women who have usually well-controlled epilepsy who have recently gotten pregnant or who want to get pregnant, and they want advice in regards to what medication they should take while they're pregnant, and also to make sure that their epilepsy gets controlled during their pregnancy. In general, we see a lot of, we work with the general neurologist on a lot of their patients if they have any questions in regards to what kind of epilepsy the patient may have, or even just to give advice in regards to what medication may be the best medication for that patient.
Okay, right. Or, other circumstances might be as, someone has a change in their seizure patterns. Maybe they're not having a lot of seizures, but their seizures change suddenly, maybe as a result of some change in their life or some change in their health. So that sounds like there's several different circumstances where that would be appropriate. Do you find that general neurologists are pretty good about referring patients to an epileptologist at an appropriate time, or is there maybe a tendency to wait too long? And is the onus really on the patient to request a referral to an epileptologist, or do neurologists generally do that when appropriate?
I think it works both ways. I think in general there have been some recent studies in some journals that have shown that general neurologists are taking too long to refer patients to see an epileptologist. And so in general, we are trying to promote the knowledge across the general neurologists to refer patients early onto epilepsy centers to ensure that they're getting the appropriate treatment, and so that they're not just trying multiple medications and still having seizures. So I would say as a part of being a proactive patient, patients should mention it to their general neurologist, but I think it's also part of the general neurologist's responsibility to identify patients who would benefit from a multidisciplinary epilepsy center for evaluation.
Right, great. And are there any disadvantages to having an epileptologist as your primary neurologist, like seeing that doctor regularly over several years? Do you have to have really poorly controlled seizures to see an epileptologist, or if someone has reasonably well controlled or fully controlled seizures, would there be any reason to see an epileptologist as your standard neurologist, or how does that work?
Well, I think if the patient's primary problem and only neurological problem is epilepsy, I think it's a wonderful idea to see an epileptologist as your primary neurologist.
Okay, great.
If you have multiple other neurological problems, for example, if you have stroke or something else, then it may be good to see a general neurologist in conjunction with an epileptologist so that we could work as a team to ensure that patient has care of all their neurological problems.
Right. And do insurance providers view epileptologists and general neurologists any differently in terms of their coverage, or is basically a specialist and they view them the same?
I think in general most insurance companies view us the same. We've had no problems with patients who have seen us and compared to seeing some of our general colleagues. So I don't think it's a big issue.
Okay. And then speaking of insurance, we do have a lot of clients who either have no insurance or have poor insurance or limited insurance and still have poorly controlled seizures. And we often, recommend if you have poorly controlled seizures and you're seeing a general neurologist and you haven't yet seen an epileptologist, we might recommend that they see an epileptologist. But the question is, would their insurance cover that? If they don't have insurance, that wouldn't cover that. And then if they do have insurance, it might not provide full coverage. So the question is it worth scheduling a single consultation with an epileptologist, even though they might only be able to pay for that out of pocket and may not be able to pay for all of the additional tests that might be associated with that consultation, like an EEG or video EEG monitoring or a new MRI or blood tests or follow-up visits. Can a single visit or a single consultation with an epileptologist actually result in improved treatment?
Well, I think if someone is having difficulty with seizure control, regardless of insurance issues, I think it's vital to that patient's care to at least see an epileptologist once. Things that we could provide which wouldn't require extra testing is that so much of the diagnosis of epilepsy and the type that you have is based on a good description of what the patient's seizure looks like. Right. And so that can do so much in that it helps us to look at what medications that patient may be on, and we may be able to give advice in regards to which medication may help a little bit more to control their seizures. And also, if we heard the history and there was something significantly vital, we could explain to the patient, I think, out of all the tests, this one may be the most important in regards to your epilepsy care.
The tests.
Exactly.
Okay.
And also here at the Hauenstein, especially as epileptologists, we're probably in the know in regards to what drug companies may be offering patient assistance programs, and that may really help the patient out, especially if they have no insurance.
Right. Okay. And in terms of, because many patients may have limited time with an epileptologist, what are some general recommendations to help patients get the most out of their appointments with an epileptologist or even a general neurologist? What are just some general tips so that they can make that 15 minutes or however long they have really count?
Sure. I think it's important to always bring all your medical records, your medications, especially for patients who have epilepsy. I think it's always important to bring someone along who may have witnessed your seizure. As I said earlier, so much of our diagnosis is based on description of what the seizure looks like, what the patient does during the seizure. And for the majority of time, the patient doesn't know, because obviously when they're having a seizure, they have no recollection or recall of what was happening. So bringing someone who can describe your seizures, how many you have, and what you do during them is very important to us. And if you have a video on a phone or on a camera, bring that too. That's wonderful, because it's a visual aid that helps us when we see you. And if you have multiple seizure types, it's always good to organize that so that when you see us, you're able to tell us, I have 3 seizure types and this is what they're like. The other things I always recommend that patients bring with them is a seizure diary so that we can know how frequently you have seizures at baseline and to see if any treatments are helping that frequency. Obviously, your medications, including all the medications that you have been on for treatment of your epilepsy from the time that you were diagnosed or started on treatment. Any old studies such as EEGs or MRIs are also helpful so that we can avoid repeating testing, especially if you had a lot of these testing at different hospitals and sites. And obviously, any questions that you have that we can answer for you is great.
Great. So, again, a lot of people are referred to an epileptologist from a general neurologist or even from a general practitioner. What are some of the most common diagnostic and treatment mistakes that you see among patients who've been referred after having initiated treatment through either a general neurologist or a general practitioner? And again, this is nothing against general neurologists or general practitioners, but just so that people can kind of be aware of possible red flags of things, common misdiagnoses or treatment mistakes.
Well, I think, one of the advantages of seeing an epileptologist versus a general practitioner or a general neurologist is that, we always want to know what kind of epilepsy you have, whether it's focal or generalized. And a lot of times what we see is that's not focused on or that difference is not made. Right. And the reason why we want to do that is sometimes it helps us decide what treatments would benefit the patient the most. It also sometimes gives us the ability to give a little bit of prognosis to the patients and their families. So I think that's one of the key things about seeing an epileptologist is that we, focus on things that may help with the treatment plan especially whether you have generalized or focal epilepsy. Some of the other things that I see when I get referrals is, the patient may be on multiple medications, but all of them are at, subtherapeutic or low doses, where, I may try to maximize one, and so the patient's not taking so many different medications at suboptimal doses.
Right.
And then also, probably the biggest thing is what we referred to earlier is waiting too long to see if there are other treatments besides medications that could help the patient with control of their epilepsy.
Right. Okay. I wanted to just talk a little bit about some of the common gaps in knowledge that we come across in talking with people with epilepsy and family members. And for each of these, if you could just talk a little bit about whether it's important for patients to know this, and if so, how important it is, and then also why it's important to know this. So often we talk with patients and families who don't know what types of seizures they have. They can maybe describe them, but they don't know the terms for them. Often, for instance, anything that's not a grand mal or tonic-clonic seizure is referred to as a petit mal seizure, and obviously that petit mal is an absence seizure, which is a very specific type of epilepsy, but it's not a simple partial seizure or a complex partial seizure. So how important is it to know what type of seizures you're having and what the correct terminology is, and then also what type of epilepsy you have, whether it's an epilepsy syndrome, or at least knowing whether it's partial or generalized, or knowing more about the cause, whether it's idiopathic or symptomatic or cryptogenic, those types of distinctions. So if you can just talk a little bit about how important that type of information is for patients to know.
Sure. I think it's very important for patients to know what kind of seizures and what kind of epilepsy they have, especially if they do have a epileptic syndrome. And I alluded to that a little bit earlier in that knowing what kind of seizures you have and the type of epilepsy you have really helps, when you're seeing different doctors, helps them direct what kind of treatment would most benefit you. Calling, everything that isn't a grand mal a petite seizure is sometimes misleading, and it's a very much outdated term, and Russ, and it doesn't really give the physician a good understanding of what is actually happening to the patient when they're having a seizure. So I think it's vitally important that patients understand whether they suffer from generalized epilepsy or focal epilepsy, and then after that to understand what the different types of seizures there are and what it means when a doctor says to you, I think you have complex partial seizures versus generalized seizures. So I think it's very important, and in my practice I really focus on the fact that patients should really be part of the medical management and decision making, and that if the patient isn't educated about what's wrong with them, it's harder to get an effective treatment plan, I guess.
Right. And I know a lot of patients are very interested in cause of epilepsy, and,
sure.
and that can certainly tell you something about, in some cases it can tell you something about prognosis, in some cases it can guide treatment, but in many cases the cause just may be unknown. And how
sure.
how important is it to know the cause, and how do you counsel patients when the cause is unknown?
Sure. There's about 30 to 40% of the patients who have epilepsy where we can't find a cause for their epilepsy, meaning we do things like MRIs and EEGs, and we can't locate where their seizures are coming from, or, we don't see a tumor or a mass or any cortical malformations to let us explain to the patient, you have seizures because of A, B, or C. And often that's very frustrating for patients. They would rather know what's wrong with them and what's causing their seizures. But unfortunately, that's not always possible to find that out. And, you know, if we do find a cause, such as a tumor, and we're able to treat that, that's a very treatable form of epilepsy, meaning that we can do something to hopefully improve that patient's epilepsy. And so that sometimes gives some patients comfort to know that this is their cause. But how I like to explain to patients is that, you know, probably, you know, if we took a piece of tissue of the brain, we'd be able to see an abnormality underneath the microscope. But based on the technology that we have, a lot of times we're not able to tell patients what exactly is causing their epilepsy.
Right. Another thing is we have a lot of people who who use the term seizure disorder, or they call and they might say, well, I don't have epilepsy, I have a seizure disorder, or perhaps they just view seizures as a symptom, like maybe they have had a stroke and they have seizures because of the stroke, or maybe they have a developmental disability or autism and they have seizures because of that, and they view seizures as a symptom or as a secondary condition. Why is it important to when you have seizures or epilepsy to view it as a separate condition? Because I think in seniors, for example, they often view seizures as a symptom rather than its own condition.
Sure. I mean, first of all, let's talk about what the definition of epilepsy is. Epilepsy simply means that you have a recurrent tendency to have unprovoked or recurrent seizures. And epilepsy doesn't tell you what the cause of the patient's seizures are. It just describes the fact that you have a recurrent tendency for seizures. There are a variety of causes for seizures, and if you've had more than 2 seizures, you fit under the definition of epilepsy. I think it's important to identify that you have epilepsy and that it's a separate condition because just like anything else, let's say if you had high blood pressure, diabetes, you would identify that as a medical condition that you have and prioritize it in regards to making sure that you treat it and making sure that you avoid triggers for it. And so I think it's important to identify to people, especially physicians, that you have epilepsy. And I think sometimes people clump that into their other medical conditions, or they're afraid there's a social stigma attached to identifying yourself as having epilepsy. But I like to tell patients that it's just like any other medical condition that you may have. It's just important to put emphasis on it and to make sure that it's treated.
Right. Okay. And so, and then lastly, knowing a lot of clients may not know what the various test results mean. They might be able to say there was something abnormal on my MRI, but I don't really understand what it was, or other patients may not know why a particular treatment was chosen. They just kind of accept that that was what the neurologist decided and that's what they're doing. Can you talk a little bit about the value of understanding your test results as a patient and understanding the rationale behind treatment choices?
Sure. As I mentioned to you earlier, Russ, I think a good treatment plan is one that is a decision made both by the physician and the patient. Because ultimately, what you choose to do or treatment for the patient affects them, including, how well their seizures are controlled and the side effects they may have from their treatment. I think it's always important before you get any testing done to ask your doctor, well, why am I getting that testing done? What will it show us, and how will it help us to make decisions regarding my care? Because it's so important, to know what does an EEG represent, and if it's normal, does that mean I don't have epilepsy? Because you may be misled by what that means. Or, what did my MRI show? Because let's say if it showed something like cortical malformation, what are the possible treatments for that? So I think having knowledge of why you're doing a test and what the test result means allows the patient to better understand why they're being treated and the medications that are chosen for them.
Right.
And it also helps them understand whether they have, epilepsy that's focal versus epilepsy that's generalized, sometimes based on their exam findings. So I think it's very important for patients to be educated about why certain tests are done and the results.
Right. Okay. Great. Well, those were the main questions that I had, and I now just want to open it up to the rest of the participants with any questions that they have. And remember, that's the title of this call is Ask the Epileptologist, so please ask away. Who wants to ask the first question?
I'll start if no one's ready.
Okay, go ahead.
This is Rhonda Harrison. Could you explain what a psychogenic seizure disorder might be and how the treatments would vary?
Sure. Psychogenic seizures are referred to, another term that some people will refer to them are stress seizures, or what we used to use the term non-epileptic spells. And how I like to explain that is that it's something that physically looks like a seizure, but isn't generated by the brain the way an epileptic seizure would be. An epileptic seizure is a hypersynchronous or increased activity of the neurons in an area where there shouldn't be increased activity. When we monitor patients who have psychogenic seizures in the epilepsy monitoring unit, we don't see any increase in brain activity or brainwave activity. And that's how we diagnose psychogenic seizures, is through an evaluation in the epilepsy monitoring unit. And oftentimes the cause for psychogenic seizures is usually some kind of stressor. A lot of our patients who suffer from non-epileptic seizures have a history of abuse, whether physical, sexual, or verbal. And what I like to emphasize is that it doesn't mean just because it's not a true epileptic seizure that it's under the patient's control. It's a subconscious response, what we describe to usually internalized stress. And the treatment is very much different from the treatment of true epileptic seizures, meaning anti-epileptics will not help treat this kind of medical condition. The treatment for non-epileptic seizures or non-epileptic spells is cognitive behavioral therapy with a psychiatrist. And usually when you get treated in that way, there's a very good success rate that these spells may stop completely. Did that answer your question,
Yes,
Rhonda?
it does. It helps a lot. And if I can, I have one more. Clozapam is as a instead of diastat for the public to use to stop a seizure. Just wanted your opinion on the safety of it.
Well, they're in the same family of drugs. If you are asking me which one would I prefer if I were to treat a patient, I would say either diastat or Ativan would be my preference to use to stop a seizure, especially one that's lasted longer than 3 or 4 minutes, like in an emergency situation. My preference would be to use diastat or Ativan. There are patients who are on clonazepam for other reasons, such as patients who have generalized epilepsy and have uncontrolled myoclonus. So there are uses for clonazepam, but for emergency abortive therapy, diastat or Ativan would be preferable.
And then the Ativan is given how?
Well, that's usually administered by EMS, but sometimes patients will have Ativan either orally through a pill, or usually EMS will give it IV or IM. Or I'm sorry, I shouldn't use those terms, intravenously or intramuscularly.
So the orally that just dissolves and you can give it to a non-responsive person?
Yes, but if you have someone who is either cognitive delayed or a child, probably diastat would be a little bit better choice, and you wouldn't have to worry so much about their airway and those kind of things. But there is a dissolvable form of Ativan.
Thank you.
And as a follow-up to that, can you talk a little bit more about a couple other options that are still not FDA approved but can be prescribed? One being the, well, I'm not sure about the FDA approval, but one being the intranasal midazolam, and then also there's a buccal midazolam, and then there's an intramuscular auto-injector system for, I'm not sure if that's diazepam or one of the others, but are you familiar with those options and where they're at in terms of approval and how they compare to Diastat for stopping seizures?
I can't tell you, I guess I can't tell you where they are compared to rectal Diastat in regards to how quickly it can be used to stop a seizure. But in general, they're all the same medication. They're just different routes or forms of giving it to a patient. Obviously, anything that you give via the IV or intravenously is going to work faster than something that you give through the muscle. Diastat works pretty quick, and I found that it works a little bit faster than the intramuscular form of these medications. Intranasally, I don't know where that is in regards to FDA approvals, but that should work just as quickly, I would imagine, as the intramuscular form.
Okay. Other questions?
I have a question.
Could you, I know, a question about auras. Is that a question that we could talk about?
What's your
Say that again, sir?
What's your question about auras? Go ahead.
How, as far as auras, do they always go into a seizure, and why don't they? I guess why don't they? And they are a seizure, right?
Right.
Yes, they are.
Huh?
So you're asking why do auras sometimes turn into seizures, or
sometimes
go
they turn into
further
seizures,
seizures, and why do sometimes they stop?
Right.
Okay. Well, auras, first of all, just to let everyone on the phone know, are kind of things that patients experience right before what they describe as going into a seizure. And it's usually the same thing. Some people will complain of smelling something funny. Some people will complain of deja vu. So something kind of unusual that happens to them that's always the same every time before they go into what they describe as a seizure. And aura is definitely a seizure. And in a sense, you can think of it as a simple seizure, meaning that you haven't lost consciousness, but there's abnormal activity going on in your brain that's causing you to feel that way. Auras are part of focal seizures, meaning that it's starting in one area of your brain. And, sometimes that activity, that abnormal activity in your brain doesn't spread to other regions to cause you to lose consciousness or to cause you to have a grand mal seizure. And so that's why sometimes all you experience is the aura. It still counts as a seizure, but it hasn't spread to areas where it would cause you to lose consciousnness or maybe cause you to jerk on one side. So I don't know if that answers your question.
Well, I've had auras, quite a few of them, and it never turned into a bad seizure until this morning. And I had an aura, and of course I knew it was an aura, so it was no big deal. And I was down in the basement, and I was going to go upstairs. And as I approached the steps, I'd had a bad seizure, and I fell on the floor. Fortunately, I didn't make the stairway. And that was the first time, and I've had epilepsy for a few years, and I said I have had auras for quite a while, that was the first time I ever had a full seizure, and I fell and passed out. And I didn't know what's the difference between this one and all the other auras that I have had.
Okay. Well, I'm sorry to hear that you had a bad seizure this morning, and I hope you're feeling okay now. I I think maybe another way to think about it or think about an aura is let's say if you think about a bullseye or a target, when you have an aura, the activity is just isolated to the middle of the target. And then as the activity increases or spreads to the other areas of the target, the bigger rings, it may cause you to have a full-blown seizure. Why it did that today and not the other days, I can't answer that. But there's different causes that may lower your seizure threshold, or perhaps, you need more medication to treat your seizures, that it just spread to other areas that cause you to have a full-blown seizure. I don't know if that helps you to think about it in a different way.
When you have an aura, then the best idea is to sit down. So you are better sit down when you have an aura.
That's probably a good practice, right? Even if they don't consistently generalize and then spread
right.
and cause another seizure. It's
better to be
safe than sorry, and it's probably a good practice.
Okay.
And
definitely agree.
Related to that, I know a lot of people don't view auras as seizures, and is it important or maybe can you talk about why it's important to track those as well, like if you're keeping a seizure diary, why it's important to track those as well and report those to your neurologist?
Sure. Well, number one, auras are a seizure, the part of the seizure experience, and I like to explain to patients that it's basically a simple seizure, and it's just important to track those as the more what people call intense seizures where they lose awareness, because with auras they can always, as I didn't get your name, but this gentleman's case spread and cause a secondary generalized seizure. So there's always a potential there. And if you have a lot of auras, it also will tell your doctor that perhaps your epilepsy isn't as well controlled as you think, and perhaps there's areas in your brain that are still quite irritable and need to be treated.
Right.
Well, I've had auras when I've been down in my lower level, and I've always felt when I've had them before, and it's been several times, and I've always thought, well, I want to go upstairs because I'd rather be with my wife, be with somebody, and sit in a comfortable chair, and I've always made it. No big deal. So it's not been a problem. But this morning I've learned the lesson. I can't do that anymore, right, because I didn't make it to the stairway.
Okay.
So
sure, I think it's important to, it's good that you recognize what your aura is. But I think, as soon as you experience it, you should get to a safe place, and definitely don't be walking upstairs and those kind of things and put yourself in any kind of dangerous situation.
Sit down.
Okay. Someone else had a question or was about to ask a question?
My question was what kind of a follow-up to the clonazepam for cluster seizures. I've seen that prescribed, and yet if they don't always specify if the cluster seizures continue. I haven't seen it prescribed for tonic-clonic seizures, and I've been told that's not really recommended. As you said, you typically prescribe Diastat or Ativan. And then I guess in follow-up to that, you mentioned the other forms of medication for generalized tonic-clonic seizures, and I wondered about the Ativan. I guess if somebody was having a tonic-clonic, is the oral dissolvable Ativan sometimes prescribed for that, or no? I wasn't clear on that.
I didn't catch the first part of your question. You said something about clonazepam for cluster seizures. I didn't catch the first part of that.
Is there, if a patient doesn't respond within, say, a 20-minute period, is the protocol then to sometimes go to a Diastat, let's say, for that? for cluster seizures. What is your protocol regarding continued cluster seizures? Is it 5 cluster seizures and then or 10 or a time frame? How and when would you prescribe something in addition to the clonazepam, if that's even what you would prescribe? That's what I have seen prescribed.
Sure. I don't have a set protocol. I think I really look at the patient and the kind of clusters that they have, how long they last. If, a patient's cluster is a cluster of complex partial seizures or versus a cluster of myoclonic jerks, I think I would treat that differently. And so I think it has to be based on the patient. A protocol should be based specifically on that patient. Sometimes if we know a patient always has clusters of seizures at a certain time of day, we may prescribe clonazepam, maybe half an hour before to see if we can abort that cluster. But I would say if any cluster is prolonged or, the patient begins losing consciousness or doesn't regain consciousness between seizures, I think it's time to get help and administer something like an Ativan or a Versed. So I think it's really patient dependent, and I wouldn't use the same protocol for every patient. And like I said, if there's any fear that the patient is not regaining consciousness in between seizures, or they're having continuous seizures that don't stop in between, I think it's always better to be safe and cautious and call EMS. But clonazepam can be used for select cases, and I do prescribe that for cluster seizures on occasion.
The cluster seizures that I guess I was speaking to would probably be more myoclonic, and the patient is regaining consciousness, but they're prolonged in over a period of, say, a half an hour, or they might be every 3 or 4 a minute, and that type of thing. Just is it kind of standard if there's some prolonged activity with maintaining consciousness, but just out of their normal pattern for cluster seizures, to prescribe a diastat as just if the seizures are out of their normal pattern and prolonged?
Sure. If they're out of the patient's normal pattern and they're clustering quite frequently, then I guess the big question that I would, pose to your doctor is, does it, meet requirements for something like a status epilepticus or prolonged seizures? And at that point, if it did, then I would say, yeah, something like rectal diastat would be recommended in those cases.
And then the other the Ativan question, I guess, is that I haven't seen the dissolvable prescribed for the generalized convulsive type seizures. Is that something that's new, or has that been? I've seen diastat routinely. I haven't seen the Versed yet, but I know it's out there. And I guess I'm not sure, if you have patients that are out in the community, obviously diastat has its drawbacks, given that it's, administered rectally if they have it on hand at home or at school. And but if they're out in the community, that Versed would be a better option, I would think.
I guess in general, probably diastat is something that I prescribe more often. There are very, very select patients where sometimes due to, injuries or certain reasons where it's difficult for that caretaker to administer the diastat, meaning they can't get their legs up or whatnot, we have prescribed on not frequent occasions, some Ativan, and we have on occasion prescribed either liquid or dissolvable. But in general, I would say diastat is something that we prescribe much more often.
And the Versed is not prescribed. Is it just not FDA approved yet for that? I don't ever see that prescribed, and I'm not sure.
I would say no. I would say the diastat and the Ativan are preferences compared to something like the midazolam or the Versed. So I would say it's not that it's not FDA approved to abort seizures. That's not the reason. It's just ease of use, safety. For example, diastat. We dose it based on the weight of the patient, and it's usually pre-programmed in the tube for a certain amount, or you can dial it up or down. And so it's relatively easy to administer, and at the dosages that is prescribed, we don't have to be worried that you're going to have any significant side effects from those medications. All those medications can cause a patient to be quite sleepy, and we worry about different things when that happens.
So more likely to have things like respiratory depression with Versed. They don't have like a metered dose intranasal mechanism.
Those things are coming out, but they're not so widely available that I prescribe those on a regular basis.
I think what you're talking about is it's not manufactured for a layperson in a form that's easy to give without having to draw up in the potential of overdose.
Right.
And that's
a big issue.
Yeah.
It's definitely a big
issue. You have to look at when you're giving emergency meds.
Yeah, because, people panic, and you want something that's, you don't have to mess around with, and especially something like diastat, you can it's pre-dialed at a certain dose, and you can administer it easily, and you don't need a ton of education or anything like that to do that.
So they don't have anything like that in the intranasal form of the Versed then?
Well, like I said, those things are coming out, but I don't use them. They're not widely available.
Dr. Tran?
Yes.
Hi, this is Renee. I'm calling from Beaumont Grosse Pointe. And I have a couple questions for you. Since we're on meds, I wanted to find out about Falbamate. Is that a controversial AED? Or is that used commonly? Or
Falbamate was introduced in the 1990s. And it is definitely not a what we describe as a first-line anti-epileptic at this current time. The reasons is that it has some significant side effects, including what we describe as fulminant hepatic failure. Not to say that there are not patients who are currently using that. There are patients who are still currently on Falbamate. But it would not be my first choice of anti-epileptic.
Okay. Can I ask you a couple other questions also?
Sure.
I wanted to know about, as far as being an epileptologist, does an epileptologist, aside from the fellowship, do they have to have boards that give them that credential of being an epileptologist, or just the fellowship?
Well, there are boards for everything, but you don't, I think most epileptologists do take boards, either in neurophysiology or boards specifically for epilepsy, but most, you can just come out of fellowship and work as an epileptologist, but you are obviously board certified in neurology. Mm-hmm. There's extra board certification for epilepsy, either via the American Board of Clinical Neurology and Psychology for neurophysiology with emphasis in epilepsy, or you can take specific boards just for epilepsy.
There's a specific EEG board as well for physicians?
Yes, that would be the boards for clinical neurophysiology.
I see. Okay. Can I ask another question?
Yes.
I wondered if you are aware of good resources for education, whether it's videos or published data that help with training techs, nurses for a seizure assessment. Just I don't know if an ACNS, if there's guidelines for EMUs, that type of thing, or even with the popularity of continuous EEG monitoring, on the floors or in the CCU, some training resources for staff so they're familiar with it and are able to, assess and handle a seizure.
Sure.
Good resources at your hospital or?
We have some resources off the Hauenstein Neuroscience website, but even places such as the ACNS will have some kind of resources in regards to how to identify it on EEG. But even the Michigan Epilepsy Foundation, if you go through their website, it's really nice in that it has sections. It's tailored more for patients, obviously, but it applies to if you're working with nurses on a general floor, how to identify seizures, what to do for emergency care of seizures, and those kind of things. So I would start there, and then if you need more in-depth training, I would ask either the epileptologist at your institution or the neurologist to kind of just review some simple safety precautions, EEGs, and those kind of things. Is there a specific website that just has all of that bundled? I have not come across anything.
In a lot of those things, and sometimes I wonder if things have been created, already, that would be, easier to follow than to, create a video or create whatever we're doing. So I just wondered if
this is Russ. I wish that we wanted the National Epilepsy Foundation to create a much more detailed and intensive DVD that would talk about, show multiple examples of different types of seizures. Because what we have, it shows maybe one or two examples of each type of seizure. But it would be really beneficial to us, and I'm sure to professionals too, if we could have something that would have 5 or 6 different variations of complex partial seizures, or show a frontal lobe complex partial seizure versus a temporal lobe, or that level of detail would be really beneficial. And I don't know if there's anything out there that would show that variety and detail of different seizure types. So,
Russ?
Yeah.
Hi, this is Kathy. I was just going to say that ever since I've been going to neurologists and doctors, I read on the notes in the doctor's office different types of seizures, and I think I've had every one. Because just like my boyfriend was saying that I had 3 the other day, and he says one of the examples is I smack my lips and I would say yup, 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 and then he asked me a question and I would say yup, yup, yup. What type is that?
Oh.
Then I like yesterday I was talking on the phone to somebody and then all of a sudden my mind went blank. It's like when you stop a VCR and you see the picture but you can't think of what's going to happen next. And then I try to tell the person, just a minute, and I try to get myself put back together, and I try to continue. Lately, too, in the middle of the night, I guess I've been having them because when I wake up in the morning, either my tongue hurts or my teeth hurt. So I'm either grinding, I don't know what type of seizure that is, if I'm having the grand mal during sleeping, or what, because what kind of seizures are those that I'm describing?
Right. Well, the lip smacking is it? Go ahead, Dr. Tran.
No, go ahead, Rick.
I was just saying the lip smacking is a common symptom of a complex partial seizure. Complex partial seizures often have, usually last a minute or two, and they may have these things called automatisms, which are repeated non-purposeful movements like lip smacking or fumbling with objects or picking at clothing or other repeated motions that don't serve any purpose. Also periods where you kind of lose time or you lose awareness but there's no evidence of having a convulsive seizure would likely be a complex partial seizure as well. Now something like where maybe you have the inability to think of what you want to say, or the inability to think of what words you want to say, and like you said, just sort of freezing, that could be more towards a simple partial seizure. But sometimes there's a blur between simple partial and complex partial. But Dr. Tran, did you want to talk more about that?
I think you're correct, Russ, and the way you described it, and I think if you're worried that you're having a lot of seizures at night, I think you really need to tell your doctor that, and that you may be a good candidate for something, some monitoring in the epilepsy monitoring unit, because seizures at night can be dangerous, especially if you're sleeping alone and you have a seizure alone in your sleep. And an evaluation such as an epilepsy monitoring unit would let you know definitively what kind of seizures you suffer from and where they're coming from. And I think, it's good to think about your seizures in the way that Russ described to you. And it's not uncommon for patients who have complex partial seizures to go on to what we describe as secondary generalized, meaning just because you have complex partial seizures doesn't mean that you can also have seizures that look like generalized tonic-clonic seizures. Okay?
Okay.
Dr. Tran, I have a quick question about non-convulsive status epilepticus. Okay, and the likelihood of that, and for people to, when intervening, I think we basically a little bit covered it. It's hard for non-licensed people to interpret when someone is possibly going into what potentially could be a non-convulsive status, and looking at the urgency of that versus knowing that they're in a post-ictal state, and the use of Klonopin or Ativan recommendations around that at 20 minutes or what, and the likelihood of injury from non-convulsive.
Sure. I didn't know if you wanted to say something before I answer that, Russ.
No, that's fine. Go ahead.
Okay. Non-convulsive status epilepticus, just to let the other people on the line know, is basically when you're having seizure activity in your brain, but you don't have any physical manifestations of jerking or anything like that, but you have altered awareness and you have decreased responsiveness, and sometimes you're in a coma-like state. The only way to diagnose non-convulsive status epilepticus is through an EEG. It's very difficult, based singly on clinical exam, to know at times whether a patient is just post-ictal or if they're continuing to seize. So if there's any question of that, an EEG needs to be ordered. In regards to treatment of non-convulsive status epilepticus, it should be treated in the exact same manner as status epilepticus, in that you should follow the protocols set up at your hospital for that. And that would include things like IV Ativan, IV Dilantin, and et cetera, without getting too much into the protocols for treatment of status epilepticus. How dangerous is status epilepticus? It can be dangerous. Unfortunately, if you don't suspect it and you don't look for it, you won't know that you have it. And, people can be seizing for prolonged periods, and that can cause damage, obviously, if it's not treated. So it can be very dangerous.
And convulsive, obviously, but non-convulsive, schools and that always worry that someone, when do we call 911 for a prolonged, confused state, and how do we know he's out of it without EEG? And that's something that guideline-wise they have a real rough time with, 20 minutes, half hour, which, and Ativan in between. A lot of times that's not defined. If you've got someone with a history of that, it's tough to teach. So your recommendations, if someone has a prolonged non-convulsive type of seizure, assessment. What would your recommendation be for parents or whoever as far as when to call 911 if it's a non-convulsive long period of seizure activity?
Okay. I think one of the things is that you really have to identify what a patient's post-ictal state is, meaning that, are they waking up in between seizures? They may be confused. They may not be able to answer the questions appropriately, but are they waking up at all? I would say if someone's having back-to-back seizures and they're not waking up at all, it's time to call EMS and get some medical help. If a patient's having seizures, that last, longer than 5 minutes despite administration of things like diastat and those kind of things, it's time to get some help. And like I said, it's, if a patient isn't waking up at all and they're completely unresponsive, there's really no way for you to tell, whether they're post-ictal or if they're in non-convulsive status. And I guess my best advice to you is to seek medical care at that point.
Thank you.
I have a question.
Go ahead.
I have another question about auras.
Yes, sir.
I'm having auras at dinner time and morning. Every morning, say right after breakfast, at breakfast, 8 o'clock, 8:30, and at dinner time, maybe like 5:30, 6 o'clock, right in the morning. And I try and watch myself that I'm not hungry, I'm not under stress, or anything. There's nothing wrong, but I am having auras. I can depend on it. I don't know. Is there any reason? Any other reason why it's inconsistent?
There are certain types of seizures which are more predominant during certain times of day. I don't think it's if you're asking me if it's anything that you're doing to provoke them, I don't think so. Without knowing your full medical history and everything involved in your case, I don't think it's, anything that you're eating at breakfast or anything that you're doing specifically. But I would say that you might want to talk to your doctor about that, and based on, your other issues, maybe they could adjust the timing of your medications. I'm not certain without knowing your full case, but I don't, if you're asking if it's something that you're doing to cause it, because you were mentioning things like stress and those kind of things, I don't think so.
Right. It might be related to the blood levels of medications at those particular times. So adjusting the timing of when you take your medications might impact. Right.
I try to correct the morning one by taking Dilantin at 4 in the morning to see if that would.
Yeah, you don't.
I would talk to your doctor first.
Right. You don't want to make adjustments on your own, but your doctor might recommend certain changes to when
your doctor might check your levels. They'll do different things to maybe adjust how you're taking medication. But I would talk to your doctor first and let them know that you have this kind of pattern, and they may recommend some different things to help you out.
Well, I'm having my blood test now right now, so.
Okay, good.
Okay.
Good.
I wanted to make sure, as we're getting closer to the end of the call, I just want to make sure anyone who hasn't had a chance to ask a question yet, I wanted to give you this opportunity. Go ahead.
Thank you. 3 quick questions about the Hauenstein Neuroscience Center, please. Do they accept Medicaid and Medicare? And would you accept a referral from a family practitioner, as not all patients on Medicaid have access to neurologists? And also, do you have any kind of boarding center like a Ronald McDonald House associated with your center?
Well, for your first question in regards to Medicaid and Medicare, yes, we do accept patients with Medicaid and Medicare. We accept referrals from family medicine physicians, internal medicine, so it does not have to be a neurologist. In regards to Ronald McDonald House, we do have things like the Hope Network House that we have here for people who need housing, but there's a different set of people who qualify or decide who can stay there.
Thank you. And Russ, I have to leave, but I want to thank both you and Dr. Tran for this opportunity this afternoon.
Great. Thanks for joining us.
Thank you.
Other questions from people who haven't had a chance yet to ask any questions?
Where are you guys? Where is located at?
Say that again?
Where are you guys located at?
We're located in Grand Rapids, Michigan, right downtown Grand Rapids, Michigan.
Oh,
okay. Other questions?
I was asking, how many times have you worked with a vagus nerve stimulator?
I do have quite a few patients who have vagal nerve stimulator. I don't know if you know anything about vagal nerve stimulators, but it's a treatment. When patients fail medications, we offer them, sometimes based on their findings in their epilepsy monitoring and evaluation, things that we can sometimes offer them include things like surgery or vagal nerve stimulator. If you're a surgical candidate for epilepsy surgery, that has been found in the studies to have a better outcome than vagus nerve stimulator. So if you're able to do surgery, I always recommend that first. And then some people either don't want to have surgery or they're not surgical candidates, and vagus nerve stimulator can be an alternative treatment. Did you have some specific questions in regards to vagus nerve stimulators?
Well, I was just told by one doctor, neurologist, that to try it out because I was the first candidate. So I was like a test experiment to have it or a choice of surgery. And I was scared about having surgery and the description that they said because I had a cyst on the left side of my brain. And they told me the results and that even though I might have surgery, I may still have seizures after I have the surgery. Or they told me to try the vagus nerve stimulator. So I tried the vagus nerve stimulator, but I still have seizures, but, I'm not as scared as if I had the surgery.
Okay, so you have a vagus nerve stimulator or you're thinking about it?
I have one.
Okay. I don't know exactly what kind of epilepsy you have and the situation regarding your surgical candidacy. Now that you have a vagus nerve stimulator, I'm sure typically your epileptologist will continue to titrate it or increase the parameters to see if it can help to control your seizures. We're not clear how the vagus nerve stimulator works, but it does work well in some patients, and in some patients it only helps a little bit. So are you having any problems with your vagus nerve stimulator?
No, the only thing is sometimes when I get that weird feeling or feel like I'm going to go into a seizure, I just zap myself. When I'm already in a seizure, my son zaps me and I come out of it.
Good.
So,
you're talking about the magnet, right? You use the magnet, and that's the correct way to use the magnet. If you feel like you're going to go into one or if you have more than one, swiping the magnet usually causes the vagus nerve stimulator to give a slightly higher output current than it's typically set at, and that the thought behind that is that it helps abort things from going on or progressing.
Right. I think an important thing for people to realize with the vagus nerve stimulator is while it often does provide that added sense of control and it can improve seizure control, it's rare that people become seizure-free with the vagus nerve stimulator alone. So just people should kind of have that understanding when they go into or when they start considering a VNS as opposed to surgery, where epilepsy surgery has at least for ideal candidates has a much higher percentage likelihood of becoming seizure-free.
Correct. and so I don't know the exact circumstances surrounding your case, but as I stated, if you have a certain type of epilepsy, especially temporal lobe epilepsy, you know, I would always recommend that if you are a surgical candidate, you know, the percentage chance of or likelihood of you becoming seizure-free is higher with surgery than with something such as vagus nerve stimulator. With that caveat more related to your case, just because you have a vagus nerve stimulator, if you continue to have seizures, surgery, it doesn't mean that surgery is not an option for you. And, you know, I don't know how far or how long you've had the vagus nerve stimulator and where you are in the titration parameters. But, you know, if you continue to have seizures and your VNS has been titrated very high, I would still talk to your neurologist or epileptologist as, you know, like I said, surgery can still be an option following VNS surgery. Obviously, it's better, you know, to have the surgery first, but it's not out of the question, I guess, if that's something you're still considering.
No, they said if I had the surgery that I would still have seizures afterwards.
Well, I mean, that's obviously always a risk of surgery is that, you know, you may still have seizures or, you know, you may not be cured. But, you know, if you, you know, one of the important things about epilepsy surgery is that, you know, one of the jobs of the epileptologist is to choose the correct candidate for surgery. And especially for temporal lobe surgery, which is the most common adult onset type of epilepsy, good candidates for epilepsy surgery based on the center, which varies, is between probably, I would say, 70 to high 80% chance of curing epilepsy. But obviously it depends on your candidacy, where your seizures are coming from, and all those different kind of things. But obviously there's never a 100% guarantee in anything that it'll take it away 100%. But if you're a good candidate, it should be a high probability.
Right. Renee, I think you had a question?
I do, Russ. I have two questions for Dr. Tran. One is, I think that I recall Dr. Tran said that she works with women with epilepsy, and what I was wondering is if, Dr. Tran, if you admit pregnant women into your EMU.
Typically, we would wait until after you deliver to admit you up into the epilepsy monitoring unit. I guess it would depend on the question that we're trying to answer. For example, if we wanted to know if you were having what we call subclinical seizures, meaning seizures that you didn't know about, possibly I'd probably admit you up there. If we were trying to see if you were a surgical candidate where we would want to provoke seizures, I would say let's wait until after you deliver. The reason is that we don't really want you to be having seizures while you're pregnant, right? The optimum goal is to have your seizures well controlled during pregnancy. So it depends on the situation, but definitely not to provoke seizures.
And I have an EEG type of question for you. Phase reversal in CZ, C3, C4, when a patient's awake, that seems to decrease with audio stimuli. Is that a normal variant?
Say that again. So phase reversals at CZ, C3?
P3, C3, CZ, C4, yeah. Just like it seems unusual in an awake state, right?
Well, most times when you see phase reversals at CZ, it's more related to things like vertex waves or sleepiness.
Yeah.
There is a phenomenon called mu, which is most common at C3, C4, which sometimes for some people can make it look like a phase reversal without actually seeing the EEG. I can't be certain exactly what your waveforms look like. And sometimes you can disrupt that with different kinds of stimuli. For example, raising your hand on the opposite side can disrupt that. So, I mean, without actually seeing the waveform, I guess I can't completely answer that question.
Well, it's just kind of an interesting looking EEG, and we're just curious about it. Okay. That's all of my questions.
Other questions?
Yeah, Ross?
Yeah.
This is Greg.
Yeah.
I got a different question for a minute. What do they mean by bipolar disorder? What does that mean?
Okay. Yeah, bipolar disorder is a type of mental illness that's associated with both manic phases, meaning you have phases where you have a lot of energy and a lot of thoughts going through your head, and you can often be impulsive and do things like that. And then you also have depressive phases where it's similar to depression. So it used to be called manic depression. But I believe that is bipolar disorder is seen more frequently in people with epilepsy than in the general population, as is depression. So, Dr. Tran, can you speak any to that?
Comorbid mood disorders are not uncommon in epilepsy. Sometimes it's due to an adjustment of having that diagnosis. Sometimes patients have that diagnosis standing before they have that before they're diagnosed with epilepsy. And also we have to keep in mind that the FDA did put out a warning that many of the anti-epileptics increase your incidence of mood disorders or depression and suicidal thoughts. So. Right,
and there are several or a couple of anti-epileptic medications that are also mood stabilizers, so they would be effective or potentially beneficial for treating both epilepsy and bipolar disorder. So that would be something you could ask your neurologist about in terms of, is the medication I'm taking currently effective for both as a mood stabilizer and for epilepsy?
That's correct.
And which are those again? Lamictal is one, and
Depakote and Lamictal, and sometimes Tegretol or Trileptal as well.
Okay.
What about Celexis? I think that's one too, isn't it?
I'm sorry, Celexa?
Yeah.
Celexa is an antidepressant.
Yeah, my doctor put me on that stuff, but I couldn't. But I got kind of weak in the knees then.
Celexa is not used to treat seizures. So if you have seizures and they're not treated, I would talk to your doctor. As Celexa is for depression and not a treatment for seizures or epilepsy.
Does depression cause seizures?
Kind of what we said is that a lot of people who have depression also have seizures, but is depression the reason and only reason why you have seizures? Not typically, no.
There is a bi-directional relationship, though. People with depression are more likely to develop epilepsy, and people with epilepsy are more likely to develop depression.
Sure, I agree with that.
Yeah, but we don't understand the actual causality, and there's still a lot we have to learn about that. So,
but you can't. You could be depressed and have a seizure, but not necessarily. So that the two don't connect.
Well, if you think about it, when you're really depressed, you're not really, you're not feeling in the mood to take care of yourself. You might not be sleeping properly. You might not be eating properly, and those kind of things can always lower your seizure threshold. But I think that if you haven't been investigated as to why you have seizures, I think that would be worth talking to your doctor about.
I have a question.
Yeah, go ahead.
So stress can cause the seizure.
It can be a trigger. It can lower, like Dr. Tran was saying, lower the seizure threshold and make it more likely for you to have a seizure.
I think you heard him.
Go ahead. You had a question? Someone?
Yes. Going back to the VNS, how old do you recommend the child to be before you do the surgery?
Well, I'm not a pediatric neurologist, and so I do not see children. I think the age varies from center to center. in regards to the age that they allow patients to be placed with VNSs. But usually, where I trained, they did not place them younger than the age of 10 years old. But like I said, I'm not a pediatric neurologist, so I don't know that data behind how early you can put those in.
Okay, thank you.
And just, that's a good time to remind people, too, that our next Learn and Share conference call is Pediatric Epilepsy Issues and Answers with Dr. Arndt from Beaumont Health System, who's a pediatric epileptologist. So a lot of the pediatric-related questions and school-related questions, that might be another good opportunity to get some more information on that call.
Is there something good for tiredness? I'm always tired.
Well, there can be a lot of different causes for tiredness. I think you should definitely bring that to your doctor's attention that you're very tired. Sometimes it can be things like medications, which can be easily fixed, but there can be other causes. So I would definitely bring that to your physician's attention because they might want to do some testing to make sure that there's nothing dangerous going on that's causing you to feel so tired. Okay?
I always do, but she says it's medication. And I try to get enough sleep, but I'm still tired. But okay.
Right. And and again, you have to emphasize that it is a problem, that it's affecting your quality of life, and even if it is a side effect, that can be adjusted. And if adjusting the medications doesn't help, then you may want to, maybe a sleep study might be something that's beneficial to see if your sleep is being disrupted in any ways, because anti-epileptic medications can disrupt sleep. Epilepsy is more associated with sleep disorders, or increases the risk of sleep disorders like sleep apnea. So there may be other things going on that are contributing to your feeling tired that can be addressed. So I would continue to be persistent about that, and also maybe talk to your general practitioner about it as well.
I would definitely talk to your general practitioner about it.
Okay, it's about time to wrap up. Does anyone who hasn't had a chance to ask a question, does anyone have any last questions? Okay, well, thank you so much, everyone, for participating, and thank you, Dr. Tran, for all of your time and sharing your expertise with us. We really appreciate that, and I learned a lot.
Thank you very much.
I hope everyone else did, too.
Thank you.
Appreciate it.
My pleasure. Thank you for having me.
Thanks, everyone. Bye-bye.